Good morning, good afternoon, good evening. I would like to welcome you to Global Grand Rounds on novel technologies and treatment strategies for head and neck cancer. Today's Global Grand Rounds are in collaboration with Taiwan Head and Neck Surgery Society. Thank you to the Society for participation and for support of this Global Grand Rounds initiative. My name is Maria Serna, and I'm the International Coordinator for the American Academy of Otolaryngology and Head and Neck Surgery. So today, as always, we have a wonderful registration from people around the world from 123 countries, and we have over 1,100 registrants. And please, participants, introduce yourself, put in the chat which country you're from, because we would like to hear from all of you. And thank you again, welcome, and we're looking forward to this wonderful event. So today's agenda is going to go through introductions, and also we have a very nice panel, experts in the field. We'll talk about robotic surgery, immunotherapy, head and neck cancer and skin cancer, role of HPV. And please make sure, if you have any questions during the talks, place them in the because anything you put in the chat is not going to be answered. So I want to emphasize all the questions go into the Q&A. And panelists will try to answer some of them live, and then some of the questions are going to be answered at the end of the discussions. With that, I would like to introduce Dr. Eugene Brown. He is from Charleston, South Carolina, where he has in charge of a large private practice. And he's our president. He's the president of American Academy of Otolaryngology and Head and Neck Surgery. So Dr. Brown, please give a few remarks.
I guess I'll start by saying happy Saturday. Maybe that accounts for the different time zones. It's my great pleasure to welcome you to this Global Grand Rounds this morning. On behalf of the American Academy of Otolaryngology Head and Neck Surgery, I represent them as the president this year, and it's a great honor to be a part of your presentation today. We have an excellent panel of speakers and topics representing updates in the field of head and neck surgery. I know everyone's excited to jump in. It's obvious that this is a very popular and pertinent topic, as we have what an amazing number of registrants for today. And we're so excited to spend the next couple of hours in collaboration with everyone from across the globe. I think it's something that really makes our specialty so collaborative, and we just lift each other up in our care across the world. And I don't want to prolong the introductions anymore. I do want to shout out to our colleagues from Taiwan as the program is presented in collaboration today. I welcome you again to the program and turn it back over to everyone and hope it's a meaningful interaction today.
Thank you, Dr. Brown. Dr. Rahul Shah, the CEO and Executive Vice President. Dr. Shah, thank you so much for your continued support of this initiative. And if you would like to make some remarks.
Welcome. Thank you all very much. As Dr. Brown said, first, we'd like to acknowledge our Taiwan Society for partnering with us in the Global Grand Rounds. I'm going to pause and ask everybody to go to the chat. Let us know where you're from. This is the exciting part of my weekend, these quarterly Grand Rounds. Take a moment, let us know where you're from. I only see a few. I see Romania, New Zealand, Bahrain, Portugal, Mexico, Romania. It's absolutely amazing. Philippines, keep it going. Let's see really how global we are with 123 countries. Thank you from India, Switzerland. We have much gratitude for our presenters taking time to share in the global otolaryngology community. I also want to take a moment and let you know about an initiative that Dr. Brown has continued from my predecessor, Dr. Denaney. We call this One Otolaryngology Head and Neck Surgery, how we all stay together as one. And our global community represents One Otolaryngology Head and Neck Surgery. You can read about it in the bulletin. You'll hear about it at the annual meeting. But it's Dr. Brown's vision to bring us all together. And there's nothing more important than our global Grand Rounds in bringing us together. So go ahead, take a moment, put it in the chat. Dr. Serna, thank you so much for all you do on behalf of our international members.
Thank you, Dr. Shah. Thank you, Dr. Brown again. Again, thank you to all the panelists and participants. And with that, I would like to introduce Dr. Chen-Chi Hao, who is a founder of Taiwan Head and Neck Society, and he's also our International Advisory Board for American Academy of Oncologic Head and Neck Surgery, past president. So, Dr. Hao.
Well, yeah, thank you, Maria, and I'm really honored to speak here to give you a brief introduction of the Taiwan Head and Neck Society, THNS. The THNS was initiated and established in 2006 by 94 members and myself. The aim to establish the society is really trying to build up the Taiwan standard by enrolling head and neck surgeons, or maxillofacial surgeons, medical and radiation oncologists, and any medical doctors or researchers in Taiwan, and who are really interested in the management of head and neck tumors. Our society, THNS, is truly a multidisciplinary society since its beginning. The society really grows up and expands in the society members and activities along the world, along the years. And currently, we have around 500, more than 500 members, and we host at least one national meetings each year and several seminars, workshops, and we are actively engaged in nearly every international head and neck meetings. The THNS, since its establishment, has an extraordinary tight bond with the American Academy. And you can see most of the THNS members were actually American trained. And for example, one of the moderators here today, Professor Stella Tsai, he was a graduate from Brown University. And one of the speakers tonight, Professor Xixi Wang and myself were Professor Jim Mao's fellows in UPMC some 20 years ago. And we also, the members in THNS also actively participate in annual meetings of the American Academy every year. We also organize and host combined global symposiums with the American Academy, and like the symposiums tonight. And actually, every year, THNS annual meeting was a joint meeting with the American Academy in the past 20 years. And our members also actively joined and engaged in international affairs under the Academy platform. I was honored to be the 2023 International Advisory Board Chair, and personally organized and host several global educational symposiums in the past 10 years. And THNS and American Academy are really like brothers. We share the same goal and mutual interest to pursue for global education. And with that, THNS are honored to be partners again with the American Academy tonight, today, to present a global symposium today. So welcome, and please enjoy the program. Thank you.
Thank you, Professor Chen-Chi Hao. And with that, I would like to proceed with introducing our panelists. So I want to thank first of all, thank the moderators, Dr. Stella Chen-Tsai and Dr. Wojciech Mildrash. So Dr. Stella Chen-Tsai is Vice Superintendent at Taichung Metro Harbor Hospital, an Associate Dean and Professor at the College of Medicine, National Chongqing University of Taichung, Taiwan, a senior head and neck surgeon with over 25 years of clinical experience. She specializes in minimally invasive and function-preserving treatments of the head and neck cancer, particularly transoral robotic surgery and minimally invasive robotic approaches. And she has performed more than 500 robotic cases. Dr. Tsai has been a Da Vinci head and neck instructor and robotic observation site faculty, who is training surgeons in Asia Pacific region in advanced robotic applications for oral cavity and oropharyngeal cancer. Her research spans oncologic surgical innovation, peri-operative workflow optimization, and outcome prediction in the era of immunotherapy, including biomarker-based prognostic modeling in patients receiving immune checkpoint inhibitors. And then Dr. Wojciech Meldresh, who is Director of Head and Neck Surgery in the National Capital Region and Associate Professor in Otolaryngology and Head and Neck Surgery, Oncology and Neurosurgery at Johns Hopkins University School of Medicine. He has completed his training in surgical oncology and skull-based surgery fellowship at MD Anderson Cancer Center and has special interest in minimally invasive robotic and laparoscopic skull-based and endocrine surgery. His clinical research interests include surgical and non-surgical treatment outcomes in head and neck cancer patients, molecular biology of head and neck cancer, clinical applications of novel targeted cancer therapies, robotic and laser surgery, and minimally invasive surgical approaches to head and neck cancer. So Dr. Tsai, Dr. Meldresh, please take over and introduce the panelists, and please, participants, enjoy our program.
Well, first of all, I want to say welcome to all across the world. It's a sort of tumultuous geopolitical climate that we currently have. With even now, I just got a message: the airspace is closed over the Middle East. I hope everybody stays safe. If we have faculty and members joining from those areas, really trying times in the world. But I'm glad we can have a chance and a venue to come together and sort of spend about an hour to sort of learn more. These are topics that are very on the go and on demand with some of the world's best speakers and experts in the field. So I appreciate and I'm honored to be able to moderate and help moderate Dr. Tsai. So Dr. Tsai, go ahead, take it from there and introduce, and we'll have a great 1 hour, and hopefully everybody learns a little bit more from all corners of the world.
Thank you, Dr. Millards. Good morning, good day, and good evening to all our global participants. I'm Dr. Stella Chen-Chi from Taichung, Taiwan. It is a true privilege to be here representing the Taiwan Head and Neck Society in this collaboration. I have the honor of introducing our first two highly distinguished speakers. We'll begin today with Dr. Chen-Chi Wang. Chen-Chi Wang is a full professor at School of Medicine, National Yangming Chiaotong University, and the postbaccalaureate program in medicine, National Chongqing University, Taiwan. He's a senior attending surgeon in otolaryngology head and neck surgery at Taichung Veterans General Hospital. Professor Wang is internationally recognized for his clinical expertise in fullness surgery and robotic head and neck surgery. Since 2010, Wang has pioneered head and neck robotic surgery in Taiwan, establishing the country's first Da Vinci robotic surgery case observation site. He has played a key role in expanding transoral robotic surgery beyond oropharyngeal cancer to include hypopharyngeal and laryngeal malignancies, with a strong emphasis on organ preservation and functional outcomes. We will now hold all questions until the end, where Dr. Millards and I will lead an 18-minute Q&A session. Please place all your questions in the Q&A text and not in the chat box. Without further ado, let's begin now. Dr. Wang, the virtual floor is yours.
Yeah, thank you, Stella, for your nice introduction. I'm Dr. Chen-Chi Wang. Could you see my slide now? Yeah, okay.
We can see him. We can see him.
Yeah, dear global colleagues, have a good day. I'm Dr. Chen-Chi Wang from Taichung Veterans General Hospital. It's my great honor to be the first speaker in this global grand round, and my topic is the transoral robotic surgery for upper aerodigestive tract cancers. And first of all, I would like to thank my dear THNS colleagues for supporting me, and also all the American Academy members who organized this wonderful global grand round. Specifically, I would like to express my sincere gratitude to my mentor, Professor Eugene Myers, because in year 2009, when I told him that we have a first generation Da Vinci robot in my hospital. He encouraged me by saying that, why don't you use the Da Vinci robot to do the surgery for head neck cancer patient? Therefore, I start my first robotic head neck surgery program in Taiwan since the year 2010. And fortunately, I have the chance to use the first to fourth generation multi-port system Da Vinci robot since year 2010. I found that the whole platform become better and better for doing the head neck surgery. And last year, 2025 May, we also started the Da Vinci single port system, and the single port system is better for performing the transoral robotic surgery. And in my talk, I will share my experience about how to evaluate the exposure during the transoral robotic surgery and how to choose a good candidate, and explain why we use TORS for upper aerodigestive tract cancers, and my experience on using TORS for oropharyngeal cancer, hypopharyngeal cancer, throat cancer involving the anterior commissure, and also even total laryngectomy for recurrent throat cancer. And if you can see this video, theoretically, if we can put the endoscope into the upper airway and the endorisity instrument into the airway, we can then control the endorisity instrument and work with our assistant at the bedside. And it's just like put our eye and our hand into the airway to do the open surgery. And there is a slogan from the intuitive company. They say the future is intuitive. But for head neck surgery, I think innovative treatment is our future. To perform a successful TORS, we need a good exposure. I usually use the modified FK retractor to test drive the exposure during my laryngoscope biopsy for diagnosis malignant disease. As you can see, I use a 30-degree up rigid telescope to do a rehearsal, and then I can preview the surgical view before the true transoral robotic surgery. And according to my experience, by using multiple platform, we need to open the patient's mouth at least 3 centimeters wide. But by using the single port system, we can open the mouth only 2.5 centimeters wide. And we also can use 3 instruments to do the surgery deeply into the hypopharynx or the larynx, as shown by this picture. But why we use a $3 million machine for treating upper airway cancers? Because we want to avoid the invasiveness of the open surgery. We want to avoid the long-term complication of the chemoradiation. Because after chemoradiation, the organ preservation does not always translate to functional preservation. And we also want to avoid the piecemeal resection. Usually we performed by using CO2 laser because of the line of sight limitation. And when we work through the very narrow conventional digital laryngoscope. Contrarily, if we can perform the TORS with the neck dissection, we can achieve embolization of the primary tumor. We can determine the true pathologic stage, and we can then precisely plan our adjuvant therapy. The goal is to preserve the organ and preserve the function, and spare or de-escalate the radiation therapy, and finally, possibly increase the survival rate of our patient. Similar to other countries, we use TORS for our oropharyngeal cancer. Mostly is tonsil cancer. As you can see, we can use Da Vinci Xi robot and insert 3 instruments to obtain a better traction concentration during the delicate dissection along the buccal-pharyngeal fascia. We can see the anatomy very clearly. So we can do a compartment resection to perform the radical oropharyngectomy along the natural barrier that is the buccopharyngeal fascia. Then we probably have a margin, close margin after the end block resection, but we are pretty sure the resection is safe. This kind of a compartment resection usually remind me of the Taiwanese hamburger we can buy in the night market. And in Taiwan, we eat this kind of a Taiwanese hamburger. The meat of the hamburger looks like the tonsil cancer, and the bread is similar to the superior pharyngeal constrictor muscle. And the cream fin of the plastic wrap is the buccopharyngeal fascia. So this is the idea. We can obtain the close margin, but the resection should be safe. And according to our experience, most of the Taiwanese tonsil cancer does not belong to HPV positive. Only a quarter of our patient has HPV positive. But for HPV negative patient, our long-term survival was quite good, as 85% in our study. And in addition to the oropharyngeal cancer, I think we should make good use of this surgical platform to extend the utility to a deeper anatomical site and a larger resection, such as T1, T2 hypopharyngeal cancer, selective T3 hypopharyngeal cancer, early glottic cancer involving the anterior commissure, or salvage total laryngectomy. And I also perform TORS for salvage surgery. And the second application is hypopharyngeal cancer. As you can see, we can insert two instruments into the hypopharynx. We can mark the surgical incision line. We can do an en bloc resection. We can use the hemolock to secure the hemostasis. And in combination with neck dissection, we can precisely evaluate the tumor aggressiveness by the true T stage and true N stage. I think this is kind of a precision medicine. I also use a neoadjuvant chemotherapy before the TORS surgery for selective T3 hypopharyngeal cancer. For example, this tumor, after the neoadjuvant chemotherapy, was almost disappear, but I still use the transoral surgery to resect the mucosa according to the original tumor extent. And without the further radiation, the patient has no tumor recurrence after long-term follow-up. So it's amazing that we can totally spare the radiation for a T3 hypopharyngeal cancer patient. This is another example. After the neoadjuvant chemotherapy and the TORS, without the following radiation, the patient can have a long-term survival without the primary tumor recurrence and maintain a good surrounding function if the patient can spare the radiation. And according to our newly published paper in January, the clinical end stage does not correlate well with the pathology end stage in hypopharyngeal cancer. And in our treatment strategy, only 40% of our patients received the radiation to the hypopharynx. And the final survival is significantly associated with pathology end stage and extranodal extension. And our long-term 5-year survival was quite high, 77%. And the patient with extranodal extension significantly has reduced disease-specific survival rate. So that is very important to do a neck dissection. And we send many pieces of the front section with a median number of 5. Although the margin distance from at the permanent basement was only 1 millimeter, but the primary control rate was high. And 6 of our 8 patients with primary recurrence can receive the further transoral surgery and then maintain the long-term survival. And the top mortality etiology is distant metastasis or second primary cancer, but not the local recurrence. And I also use the TORS for growth cancer involving the anterior commissure because this kind of cancer has a higher local recurrence rate, poor prognosis. And by using the TORS, we can see the anterior commissure better. And according to our published paper, we can safely resect the tumor from the growths or even the recurrent cancer after radiation failure. We can obtain the long-term survival. And I think this is an innovative treatment. It's a TORS supracricoid laryngectomy with cartilage framework preservation. It's less invasive compared to the conventional open partial laryngectomy. And the disease specific survival was quite high. And the disease specific survival has no difference between the patient with spaced radiation or not. And I also performed a TORS total laryngectomy. This is the larynx I pull out from the mouth. And as you can see from this picture, the patient has only a small tracheostoma. We can spare along the cervical incision and avoid the subcutaneous edema. And most of our patients have a good swallowing function because we have preserved as much healthy mucosa as possible. And this is the 7 case we published in the Japanese Journal of Clinical Oncology. And my conclusion is TORS is an effective organ preserving, minimally invasive surgical approach for various upper aerodigestive tract tumors. We should fully utilize this technique to improve the outcome and the quality of life for patients with head and neck cancers. And finally, I would like to announce that we are going to host a third Tri-Head Society meeting this October. Welcome you to Taichung, be our distinguished guest. Thank you very much.
Thank you, Dr. Wang, for a fantastic presentation on TORS and organ preservation. Our second speaker from the Asian region is Professor Gopal Iyer. Professor Gopal Iyer works as a head and neck surgeon in National Cancer Center, Singapore, and Singapore General Hospital. He is also senior consultant of Sync Health Duke-NUS Head and Neck Center. Professor Gopal Iyer has extensive experience in the surgical management of head and neck cancers, as well as surgery for benign diseases in the head and neck, including thyroid, salivary gland, and skin lesions. He performs complex resections and reconstructions of cancers involving the oral cavity, oropharynx, larynx, hypopharynx, nasopharynx, paranasal sinuses, and neck. He's involved in the robotic and endoscopic head and neck surgical program, having performed a number of these procedures locally and mentored the first ever robotic thyroidectomy in Australia in February 2012. Dr. Gopal Iyer will guide us through the topic Peri-operative immunotherapy in high-risk head and neck cancer. Let's welcome Dr. Iyer.
Thanks. Thanks very much for the kind introduction, Stella, and thank you very much for the opportunity to be speaking to such a huge audience. It's Saturday night here, but I guess it's different time zones in different parts of the world. I'm going to be talking a little bit about something a little bit different from surgery, which is what I normally do, which is to talk about perioperative immunotherapy, because as surgeons, I think it's very important that we understand the data and the way this whole topic is moving forward, because it affects us very intimately, and ultimately we might be the ones making the decisions about perioperative immunotherapy rather than our colleagues in medical or surgical or radiation oncology, because we're the ones who usually see the patients up front. Okay, let me just get going. Few disclosures. I just wanted to give you a picture of where I live. This is Singapore. It's a nice skyline during a sunset. This is not today because today was a wet and rainy day, but usually it's really bright and pretty hot. Surgeons are always interested in immunology because the concept of being able to reactivate an immune cell is something we always deal with patients, especially in the Asia-Pacific region. We've got a lot of patients who believe in traditional medication, and they really like this idea of being able to use your body's own immune system to fight itself. And so it's something that really resonates well with our population here. Really, I'm focused on the treatment of advanced stage multimodality, advanced stage disease, as well as recurrent metastatic disease, where we're really running out of options or have limited options. And therefore, this is where immune checkpoint blockade and immunotherapy in general really has a role to play. As we all know, about almost a decade ago now, these papers came out showing the wonderful effects of nivolumab and pembrolizumab in various studies that were published across the world. And these showed actually patients who really had very poor outcomes generally at second-line treatment were outliving what was expected. And what was really amazing about these patients is there was really a flattening or a plateauing of their survival long-term, such that almost 20% of these patients who would have normally passed on actually lived well beyond what was expected. And this started this whole idea of looking into immune checkpoint blockades in different clinical trajectory. So initially we were looking really very much in the palliative setting, and then this moved into the curative setting. But unfortunately, as all of you know, most of you have seen these hype cycles, right? This is exactly what happened in the case of immune checkpoint blockade in head and neck surgery. We started off with the second line data, which showed really nice results, and we got really excited. Got into first line recurrent metastatic disease. And again, we were seeing amazing, remarkable responses of patients alive 4, 5, 6 years out from metastatic disease. And then when we went into moving this in a curative setting, we had a whole series of failures. Combining immune checkpoint blockades with radiation and chemotherapy was not the way. It didn't work. And therefore, now we move into the next phase of it, and the next phase meaning, can we now look at it in the surgical setting? In patients who undergo surgery, either in the neoadjuvant or in the adjuvant setting, is there a role for immune checkpoint blockade in this group? And that's where we are right now. As you know, the management, really, we are focused on cancers that are mainly resectable. The majority of patients that we work on in this part of the world, again, are cancers of the oral cavity. And these are the patients that ultimately go for surgery up front and then have adjuvant therapy after. Most of these patients have extensive surgery and then usually will need post-operative radiotherapy. The addition of chemotherapy can be debated based on various indications. So this is the evidence that everybody follows, right? This is the latest update based on the original Bernier and Cooper study. And it shows that the overall survival at 7 years is only 41%. And that the initial drop in the first 18 months is very, very similar across no matter what treatment you give. And therefore, it means that patients are going to do badly, are going to do badly right up front. And right up to today, we really don't have anything better than this until the most recent immune checkpoint blockade studies came out. We only debate about the margins, we debate about extracapsular spread, we debate about who gets these things, but we really need to do something to make this better, make these numbers better. And so one of the concepts that emerged with immunotherapy is this idea of neoadjuvant immunotherapy. Now, the concept is quite simple. So technically speaking, usually most of the time we do what's on the top part of it, where we remove the tumor, and then we give immunotherapy, hoping that whatever residual immune cells that are hanging around that we have not ablated somehow show up, reactivate, and kill whatever residual tumor is left. But in reality, what the neoadjuvant concept proposes is that since the tumor contains most of the immune cells anyway, let's activate this first before removing the tumor, such that there's enough immune cells in the system to be reactivated and therefore provide the outcomes that we want to achieve. And that was the concept of neoadjuvant immunotherapy. And there were several nice phase 2 trials that were done. And then we moved on to this phase 3 trial, the Keynote 689, which everybody talks about, which is really the hottest topic this year, where patients basically were randomized to 2 groups. One group that got upfront pembrolizumab for 2 cycles, and then had chemoradiotherapy, and then 12 cycles of pembrolizumab. And this opposed to the standard of care, which was surgery followed by chemoradiotherapy. And what this basically showed, I'm really cutting this short in the interest of time, but what it basically showed that the outcomes were the disease-free survival was superior in the pembrolizumab arm. So basically patients who got pembrolizumab in the neoadjuvant as well as the adjuvant therapy setting were much better off than those patients who got chemoradiotherapy. And interestingly, this was a bit better in those patients with a high CPS score, not dramatically better, just only a little bit better, which was a bit surprising. We expected these biomarkers that have worked in the recurrent metastatic setting to be better off in predicting responders, but didn't really seem to be the case. The overall survival is not yet out, but it seems to suggest there is a hint that it is improving. but take note that the improvement is like a single digit, it's still less than 10%. What's important to note is that the difference is actually improvement in distant metastatic control. And there was actually no difference in the local regional control. And this is an important concept to understand because most surgeons generally think about reduction in size as well as local regional control rather than distant metastasis upfront. And indeed, the major pathological response rate were in the region of about 10% in most of the cases studied, except maybe the CPS more than 10 group. What was good, though, was that these patients probably had less surgery and definitely had less adjuvant therapy. There was a reduction in the use of both cisplatin, as well as the radiotherapy doses were definitely lower in the patients who got pembrolizumab as part of the regime. However, the other worrying thing about this trial was about slightly more than 10% of patients never made it to surgery. And that is a worrying sign, but although it was pretty much balanced in both the trial as well as in the control arms. I think the main issue, there are several issues that this particular trial brought up. First of all, that the difference in overall survival was actually less than 10%. It was between probably about 7 to 9%, although we don't have the final results yet. So the moral of the story is that chemoradiotherapy with cisplatin is a hard drug and a hard combination to beat. And we probably, moving forward, have to think about numbers like this when planning our future trial. The second thing that was a little bit disappointing was that the difference between the two arms were not that much different in the difference in the recurrent metastatic setting. We would have thought that giving it up front earlier would show a much wider difference between those patients who got neoadjuvant. And we didn't really see that size effect that we were expecting. So what is the alternative? So the alternative is what we're more used to, right? In patients who undergo surgery, have high-risk features, and then need chemoradiotherapy, can we add on immunotherapy in this group? And this was the recent Robotics trial that was just published in Lancet a couple of months ago, although it was presented, I think, last year. In this particular trial, patients were randomized to two groups. One was standard of care, as described before, but the other is a group of patients who received several doses of nivolumab only in the post-op setting. They basically got 240 milligrams first before chemo-RT, and then another 6 doses after that. So this is in contrast to the 12 doses in the pembrolizumab trial. So a shorter course nonetheless. And you realize that when we looked at the data for this is a disease-free survival. And again, we saw a very similar difference between outcomes in terms of DFS between the control arm, which got treated with nivolumab plus CRT, versus CRT alone. Subgroup analysis didn't really highlight a major group. There was some indication that younger patients with hypopharyngeal cancers, patients with perineal invasion showed some advantage, but generally it was pretty well distributed otherwise. The benefit was mainly disease-free survival. We still don't know the overall survival result. And the effect at this time, unlike the other study, mainly affected local regional recurrence as shown here. Interestingly, in this group, they showed absolutely no correlation with CPS score whatsoever. However, it's important to note that they didn't use the standard 2C3 antibody to test their CPS score, as usually is used in most other settings. So it seems like CPS score isn't such a great biomarker of response in both studies, even though there was a slight advantage in the Keynote 689 study. So how do we decide? How are we going to pick which one? We're stuck in this situation. So in a sense, in our system and in most centers, probably payment reimbursement model will have some role to play, because if not, patients will really struggle with financial toxicity of 14 doses of pembrolizumab or 8 doses of nivolumab. I think the post-op indications are probably easier to implement because we're more used to that concept, the concept of operating first and then giving adjuvant therapy. I think the other big problem is that new adjuvant studies, I think surgeons need to understand the concept of disease-free survival, distant metastasis-free survival. You have to understand that you do not give it for downstaging or downsizing. And so there are always these debates on whether patients will get early surgical access, whether there will be delays in treatment, and whether patients may ever undergo surgery up front. And these are some of the debates that are ongoing right now to decide who's actually going to get neoadjuvant versus adjuvant immunotherapy. However, I wonder whether we might just bypass all of this. And this is some recent data that was published, that was presented at ESMO last year by Yu from Shanghai Ninth People Hospital. And this was the Cameral trial. This is a randomized phase 2 trial where they gave neoadjuvant chemo plus a PD-1 inhibitor. And this is a randomized phase 2 trial. And look at the curves here. The separation is far more distinct and far more dramatic. And what's really remarkable was you were seeing really great overall survival rates. We're talking about survival rates of over 90%, although the caveat here is this is a phase 2 trial. But there seems to be a suggestion that we may actually even bypass immunotherapy as single agent and move into chemo plus immunotherapy in the neoadjuvant setting. Furthermore, if you start looking at the response rates, we are more comfortable with this sort of response rate. 25% pathological complete response and 47% major pathological response rate. Those are numbers that I think we are probably more comfortable with as a surgeon as what you expect the downsizing of tumors. But again, the warning here is this is a phase 2 trial, and so we need to wait for the phase 3 trial before this becomes practically useful. I hope I've kind of shown you where we are right now in this whole hype of PD-1 blockade. Despite the disillusionment with combination therapy of immunotherapy with CRT, the failure of all the other combinations with CTLA4, TIGIT, LAG3, we're now here where we're seeing some pretty good results with neoadjuvant and adjuvant therapy. And remember, it's taken us more than 10 years to get here. And really, if we want to move forward, we need to really accelerate this process and do this much faster than we've done before, rather than take 10 years. So my concluding slide is that peri-operative immunotherapy is definitely here to stay. That ship has sailed. There is good and positive data for immune checkpoint blockade. The question is, before we get to implement it, will it get superseded with a combination of chemo, IO, neoadjuvant therapy? Because the results are going to look so much better in that group. The other question that probably the economists will probably have to answer is there really any advantage in giving this immunotherapy in the curative setting up front versus waiting for the recurrence and giving at that point? So we need more timeline analysis to give us that answer. I think the final point, data I didn't really show today, is that EGFR blockade still has some legs. EGFR blockade now we know is works by immune modulation. And there is some data to suggest that EGFR blockade in the adjuvant and neoadjuvant setting may have some value still to add, either on its own or in combination with immune checkpoint blockade. I mean, what's definitely certain is that we cannot wait another 10 to 12 years from discovery to application. We have to accelerate this process. And there are some really big trials ongoing in this space. And we have to do better than the single-digit DFS effects is what we are seeing here. Is the future cancer vaccines a specific T-cell type of activation using bispecifics? Or maybe biomarkers would guide us better, but either way, we need to do better. So I think that's all I have for today, and I'm happy to take questions either in the box or at the end of today's program. Thank you.
Thank you, Dr. Iyer. A couple thoughts. First of all, thank you for bringing up the question and answer part. Please definitely put questions into the Q&A chat, or not the chat, the Q&A section of the program. Otherwise, I will be forced to call people out and ask them to ask questions. I'm joking, I will never do that, but or you will field questions for me. I have plenty, but definitely, please, we want to make sure this is an exciting platform for you all to ask the questions that you have. Imagine this is at a meeting where you're seeing with Dr. Iyer, Dr. Wang, and you can ask them the questions. You're one-on-one, except for 1 to 300 maybe. But feel free, don't be afraid and don't be shy. No questions is a bad question. We'll try to tackle it at the end. So appreciate everybody participating and sort of thinking about it. One thought is, I think we're behind on some of the other tumor sites. The lung, colorectal are much more further away. But don't lose hope. Dr. Gross, who I'm going to introduce in a minute, will give us some hope. I think we're ahead on the cutaneous side of things, not just the melanoma side and Merkel cell, but non-melanoma side as well. So there is some hope. As surgeons, we love to take charge and make the decisions. And as I like to say, my job is to make sure nobody ever gets radiation. Hopefully, there are no radiation oncologists that take that the wrong way. But we're getting there. It's just the burden is on us to make sure we do the right surgery and get the right margins. So I will let Dr. Gross sort of tackle that one, hopefully, when he presents some exciting data and where we're going for the future on the cutaneous side. But again, it gives me the most pleasure. So thank you again for the speakers so far. These are two of my closest, maybe not closest, but definitely mentors and people who have trained me, and I still go and ask questions whenever I can. So I'm excited to be able to introduce Dr. Gross first. He was about to come to MD Anderson when I was interviewing, so I was excited to see that, and I did get to spend some time with him on the training robot model, so that was great. The two-surgeon console with the robotic system. I will say that I was probably one of the first physicians, actually, I'm pretty sure, that went to the official intuitive single port training in the U.S. I didn't participate in the trial, but I was in the first 5-surgeon panel that actually went to Sunnyvale to train on the single port robot. So hopefully that that's an exciting thing for me when I found that out when I was there. But Dr. Gross is a professor of otolaryngology, head and neck surgery at MD Anderson. He's been there for over a decade. He's a fantastic speaker, but also a surgeon, clinician, scientist, and just a great physician all around. He's really led the efforts for the cutaneous side, but not just the cutaneous side, but in terms of looking at neoadjuvant responses and then now asking the questions of risk-adjusted surgery in the current world we're in, and answer that question: is it safe to do? Can we do it? And how well we can do it, and hopefully affect a change in sort of the management of advanced cutaneous squamous cell carcinoma and others. I will say, we had the standard of care has changed in that, where we actually do more and more immunotherapy-based approaches prior to any surgery on this side of the cancer, not mucosal, although we're getting there as well, as you just heard. But your comment to Dr. Iyer about EGFR blockade, those patients that don't respond to immunotherapy still respond to cetuximab. So I have 2 patients currently that have failed immunotherapy, we're proceeding with surgery, but now on cetuximab. Again, I think there's different ways to approach this, and I'm not sure we can extend that out too. But it's we still have some hope when immunotherapy blockade maybe not fails us, but doesn't give us the results we need. So I'll stop talking. Dr. Gross, fantastic to see you again as always. Thank you so much for joining and participating in this global grand rounds. Take it from here.
Thank you, Wojtek. It's great to be here. And what an amazing lineup of speakers. I really enjoyed Dr. Iyer's talk that we just had. For so long, as this slide shows, I felt like I was in the desert. There was nobody else around thinking about neoadjuvant approaches and just novel approaches. But, in fact, there's plenty of us around, and, it's really exciting. I'm always happy to talk about response-adapted oncologic surgery for head, neck, and skin cancers. That's what I've been tasked to do. But I'll just start by saying there's very little data in this space. And so a lot of what I'm going to talk about is forward thinking. As Gopal just showed, in the trials so far for the vast majority of head and neck cancers, there's no adaptation of surgery. These are my disclosures. And I'll disclose I'm a surgeon, as most of us are, I think, here. And just remind folks that primary surgery remains the standard of care for most head, neck, and skin cancers around the world. I mean, that's still many of the cancers we treat, salivary, thyroid, many skin cancers, and mucosal cancer, still the standard of care is surgery. So I've been a full professor now for quite a while, and I remember back when induction chemotherapy was promoted and thought to be a strategy to improve survival in head and neck cancer. But in fact, it was never shown to improve survival, and not just in head and neck cancer, but in any solid tumor. And so it's really gotten a bad name in our specialty. But there's still patients where we thought about this strategy, and specifically in 2 camps. One, patients who refuse surgery. So there's patients who refuse surgery, and there's patients where the disease is so extensive that it was used as a test of the biology. And here's a patient in the former category. He's a SWAT team commander, police officer in Arkansas, with tumor nearly replacing his tongue, going completely across. And he was advised subtotal glossectomy with adjuvant radiation, but refused. And so he was treated off trial with a neoadjuvant chemotherapy approach in the hopes that he would have a response. And in fact, he did have a response to treatment. You can see in the baseline images on the left, and then after treatment, that there was significant clinical and radiographic response. And this allowed him to go on to have surgery. The surgery, instead of being a subtotal glossectomy, was essentially a hemiglossectomy, an adapted surgery. With histologic control of the margins. There was residual cancer there, but the margins were clear, and he was effectively downstaged, including having bilateral neck disease at baseline to pathologically unilateral neck disease. He got adjuvant radiation and did well. In fact, it became a part of a virtual tumor board that we published, and the patient, John Smith, is one of the authors on this. And so, over a population, likely not to improve survival, but for an individual, particularly who responds, one of these deep responders to treatment, there is maybe a window of opportunity for preservation of function in a patient like this. Now, neoadjuvant is not the same as induction. And it's really important to characterize the differences between these. The main point is that patients who have induction treatment are treated generally non-surgically, where the response assessment is clinical, it's radiographic. Whereas patients treated neoadjuvant have surgery by definition, and we have pathology to use to guide us in further treatments in that setting. Now, what's different from the patient I treated before? Well, of course, now we're in the era of immunotherapy, which was so nicely outlined by Gopal. And so this has allowed us to think differently about tumors, and we're seeing it across cancers. So this is the data for advanced resectable melanoma, showing that a neoadjuvant approach is superior to an adjuvant approach. These are the data for MMR-deficient colorectal cancer. This is presented by Miriam Chalabi out of the Netherlands, showing near universal responses to neoadjuvant immunotherapy alone for advanced resectable colon and colorectal cancer. If we look at triple-negative breast cancer, the standard of care now is chemo-IO followed by surgery and then adjuvant immunotherapy. And it's the same story now in lung cancer. Multiple randomized phase 3 trials read out in 2024, establishing perioperative chemo-IO as the standard of care in this disease. Muscle-invasive bladder cancer is the same story. Most recently, the Matterhorn trial was published for gastric and GE cancers. And of course, as was outlined just recently, in head and neck now, we have FDA approval for neoadjuvant or perioperative immunotherapy alone. Now, what I've been struck by is that if you look at the schema for all of these trials, the box for surgery is always the same. Call it the little blue box, right? So there's a lot of detail. This is the 689 trial. And you can see surgery is just called surgery. This is a lung trial, non-small cell lung cancer, Keynote 671. Surgery is it's just surgery. And this is the Matterhorn trial that I mentioned before. Again, surgery is just surgery. So there's not been a lot of discussion around adaptation of surgery. And in fact, across all of these trials, there's no adaptation of trial. So the extent of surgery after neoadjuvant treatment is the same as it was at baseline. That is the standard. And why is that? Well, there's oncologic concern with adapting the surgery. Does the tumor shrink concentrically, or do you get this more scattered approach to response? And, in head and neck, we're not the first ones to tackle this problem. In breast cancer, they've been giving neoadjuvant chemotherapy for decades. And they've even outlined the different types of responses that you can see, this concentric all the way to a more scattered response to treatment. And the question is is it different with immunotherapy? Does immunotherapy push us to a more concentric response than we see sometimes with chemotherapy? And we don't know. We don't know, but it's a very interesting thought process to think about. Now, I've spent a lot of time managing and thinking about treating patients with advanced cutaneous squamous cell carcinoma. It's a different disease than mucosal squamous cell carcinoma, and it's something that we see a lot of in the US and of course in Australia. This is one patient who presented with a neglected tumor of his cheek, and he was enrolled in the window of opportunity neoadjuvant trial that we had at MD Anderson. He was treated with 2 cycles, and you can see the tumor shrunk quite a bit. But because this was an early trial in 2017, there was no adaptation of the surgery. So he, at the time of surgery, had a radical excision of the cheek, auriculectomy, lateral temporal bone resection, parotidectomy, neck dissection, and free flap reconstruction. And in fact, all that was left in this tumor was 5 millimeters of residual cancer. The majority of this was just eschar, no remaining tumor. And so we took that lesson from that this disease, cutaneous squamous cell carcinoma, is exquisitely responsive to immunotherapy in a lot of patients, not everybody. But we wanted to adapt that into the confirmatory phase 2 trial that was conducted in the US, Australia, and Germany. And so it was really important that the patient still had curative intent surgery, but it allowed for adaptation of the surgery as long as it could be done oncologically. And we had to define that in the trial for how that could be done safely. But as a proof of principle, we showed that you could do this and preserve function in patients who would otherwise be at risk of losing function. So these are 2 patients that were included in the trial. They had tumors involving the orbit, and at baseline would have required an orbital exenteration. Both of these patients responded to neoadjuvant cemiplimab and had a response-adapted surgery that allowed for preservation of their eyes. And so as a proof of principle, it showed that we could do this. And in fact, oncologically, the survival was excellent for this trial cohort. Now, we've published a series of these. The reference is given here. This is by a former fellow of mine as well, looking retrospectively at patients who were treated neoadjuvant. And because we were on this learning curve, some of the patients who were involved, all these patients with cutaneous squamous cell carcinoma, some of them had an adapted surgery. So as the tumor shrunk, the margins of resection shrunk as well, and some did not. Some were treated more conservatively. And what we showed is that the oncologic outcomes were the same, that you could, in patients who responded, you could safely adapt the surgery. And we've incorporated these lessons into a randomized phase 3 registrational intent trial for patients with advanced resectable cutaneous squamous cell carcinoma. And here's one of the patients that is included in the trial. So you can see he had this recurrent tumor of his left cheek with even a satellite nodule deep to this and some infraorbital nerve symptoms. You can see after 4 cycles of treatment a significant clinical response, but there was still not normal. There's still something there. And the question is, well, how much of this is cancer or just scar? And so he went to the operating room. You can see here on his cheek, there's still this area of induration, firmness, and redness. This is outlined, as you can see in this image. I first drew out a 1 centimeter margin of resection. This would be our standard margin of resection for cutaneous squamous cell carcinoma, but not knowing if this was histologically positive or not, I drew then a tighter margin, a 5 millimeter margin around this. And in fact, this patient went to surgery, had this resection, margins were confirmed negative, and on final subsequent pathology, he had a complete pathologic response. Now, this patient could have been treated with Mohs surgery as well in a setting like this, and I think that would have been effective. But it shows that in these patients who do respond, it is possible to adapt the extent of surgery significantly. Now, I'll just highlight that this is very different than mucosal head and neck cancers that most of us treat, where, as Gopal showed, the pathologic responses are much more muted. It's about 10% of patients have a response to immunotherapy alone, and there's no data that shows that we can safely adapt the surgery in those patients. The key in either way that you do it is this concept of peripheral on deep and on FOS margin assessment. So you're assessing the margins completely, and this can be done again in a Mohs setting or in the operative setting. The coordination between surgery and pathology is critical. And so I mentioned before that we've incorporated this into NRG-HN14. This is the randomized registrational intent phase 3 trial. This is open in the US, Canada, and Australia, and we're accruing very well for this trial. And we hope that this will establish a neoadjuvant approach for this disease. This is the schema from the trial you can see here, and most importantly is that patients who are treated in the experimental arm, so they have neoadjuvant immunotherapy and they have response adapted surgery, that if they have a pathologic complete response, then they go on to observation. They have no further treatment. This is really, really critical then, that the surgery is done right, that we get enough tissue to rely on that pathologic response for deciding adjuvant treatment. Whatever it is, we've included this into the surgical training for this trial, and the bottom line is that margin control of the primary tumor is after response to treatment. That you can draw your lines around the tumor as if it was a primary tumor to begin with. Here's an example I'll show briefly of a patient who had a tumor involving the entire lower lip. It's mostly submucosal. You can see on the axial imaging below. This is what it would look like with surgery up front, near total resection of the lower lip. After neoadjuvant response to treatment, significant clinical and radiographic response, but there's still not normal in that area. There's still firmness and induration. You can still see on the scan some enhancement. So he had a wedge resection, confirmed negative margins on frozen section, and subsequent final pathology showed no evidence of cancer. So he was done. No radiation, no further immunotherapy. Here's an example of a patient who progressed. Not everybody responds to neoadjuvant treatment with this disease, and progression is a real problem. It's at least 15% of patients. You can see what it would be at baseline. Here it is after 2 cycles of neoadjuvant treatment. Clear progression of disease. This patient needed a bigger surgery. And in fact, I've had patients who've progressed to a point where they've lost function, lost the
may have lost Dr. Gross. We could ask everybody to just bear for a little bit as we challenge the Wi-Fi and internet connections of the world. As you can see, things can go on pause. So I will reach out to him as well, but we give a
in the meanwhile, while we're getting him back online, do you want to sort of address maybe some of the questions
Yeah, there's a question. There's definitely one question. So I'll go to the QA because I think there were things that were being placed in both. I think most of the questions were handled by Dr. Iyer already for the questions that were asked for those people that could see. But one of the comments is, there's the use of neoadjuvant. I'm just going to read what was said, but neoadjuvant chemotherapy and induction chemotherapy people are using interchangeably. I think that is different. There is a difference in that. So maybe I could ask Dr. Wang, Dr. Iyer to tackle that one, sort of what should we be calling these approaches and what are the difference between those two are and how we should go about. And then we'll go back to Dr. Gross, maybe handle that just one question.
I mean, I guess it's a matter of terminology, right? I guess both induction as well as neoadjuvant can be used somewhat interchangeably. Although induction generally, we tend to think of it more as pre-surgical. But I think the idea of peri-operative immunotherapy is probably something that's more relevant to the way we think. And as Neil has shown very nicely, it's a concept that's cut across a whole range of malignancies in breast, in esophageal cancers, in certain types of colorectal cancers. The idea of peri-operative means that you kind of almost sandwich it. You give it pre-operatively as well as immediately post-operatively. So I think that is a concept that we have to think about more and more, that it is really sandwiching across surgery. So it's not either before or after, but it's really peri-operative.
Thank you, Dr. Wang. Do you have anything to add to that? Otherwise, we'll go back to Dr. Gross.
I think it's a very good concept. We use immunotherapy before the surgery, just like we use neoadjuvant chemotherapy before the surgery. But in our experience, the neoadjuvant chemotherapy is effective for our Taiwanese patient. And the problem of immunotherapy is the cost is very high. So we need to consider the cost effectiveness. And also some of the attendees asked a question about the pseudo progression of the tumor. There's possibility of the pseudo progression of the tumor. So I think it is a very important issue we need to deal with, in the future, if you want to make good use of this kind of a concept. Thank you.
Yeah, Boytek,
Thanks,
I apologize. Yeah. I don't know why I'm just not able to log in except on my phone right now. But okay. I think this is actually great because the discussion is really wonderful. And I was honestly kind of wrapping up my time. Okay. Anyway,
do you want to just share some final thoughts, kind of the conclusions, and then we'll keep going. I appreciate it.
Yeah. So the question about response adapted surgery, the truth is we adapt our surgeries all the time, right? We see patients with all sorts of different tumors. You can have a small T1 cancer. That surgery is different than a larger T3 tumor or a T4 tumor. So we by nature of what we do adapt surgeries. And so this is just another wrinkle in that. And how do we adapt our surgeries after neoadjuvant treatment? And neoadjuvant treatment is not going to be for everyone. It's going to get much more complicated as it's in head and neck, maybe a chemo-IO or multiple drug strategy potentially offered for surgery. And I think the key is for surgeons to be engaged in these discussions. Surgeons need to be seeing these patients up front, helping them decide what's going to be the best option for the patients, monitoring them for response to treatment because patients, there is a real risk of progression. And then at the time of surgery, giving them the right surgery so that you have pathologic information. So I think I'll just kind of leave it with those thoughts and really, again, I apologize for the technical challenges here, but really wonderful discussion, and thanks for including me.
Thanks, Dr. Gross. Again, always great to hear your thoughts, and not just your thoughts, but the sort of the evolution of where we are and where we're going forward. And this is a great segue to our next speaker. Dr. Fakhri always keeps us grounded and realistic with when we talk about things at our tumor conference and team meetings, that we need to always stand on data and be able to show what we want to do. And I think that's the one of the things that I think she is a champion of, but also critical for us to look at these and ask all these questions, but on trials. Before we make the leap forward, we don't want to make the mistakes that maybe not the mistakes, but the failures we saw with original induction chemotherapy in the larynx trial, in the laryngeal cancer trial, where there were a lot of recurrences when you went with the induction responses to do less surgery. So we have to really, beyond the proof of doubt and with great data and prospective trials and registration, make sure that we can actually answer those questions. Can we really do response adjusted surgery for many of our tumors? Do we have these concentric responses? Are we allowed, or will we be able to not de-intensify, but maybe more tailor the therapy to the biologic response? And then the risk, again, of pseudoprogression, we didn't hear much about it, but we've recently had patients who've really pseudoprogressed very quickly. It was sad to see on our trials, and these are combo immunotherapy trials, that we can get real hyperprogression of tumor. And so we still have a lot of questions left unanswered, but I think asking them in collaborative approaches with clinical trial data and prospective registry and looking at pathology is very important. The other issue is, how do we adjust the surgery? Because we know from Dr. Gross's first trial that on the cutaneous side, that radiographic responses doesn't mean actually that you get partial response on imaging, but you actually get a complete response on pathology. How do we align those two to make sure we make the right decision? So again, lots of questions. It's going to keep us busy for the future, but I think this is great to have something to reach for, and hopefully get better results with less toxicity and less invasive approaches. So on that mind, I want to introduce again a colleague, a mentor, and really a true friend, Dr. Fakhri, who I will say, a little embarrassing moment, that I used to take a call together with Dr. Fakhri when I was a junior resident. She was my senior resident. So I've learned a lot from her over the years and now decades. She really has a fresh look at human papillomavirus associated disease and how we can monitor, survey, and sort of change how we've done things. And it was really at the forefront of pushing that early on when we still didn't know much about human papillomavirus. So again, she's a professor of otolaryngology at Johns Hopkins University School of Medicine. That's a lot to say, a lot of S's. She's now a leader in our School of Medicine as well, helping us sort of move forward. So again, I appreciate you joining us on a Saturday morning. For some people, it's afternoon or evening. So thank you for all still sticking with us. And again, please put your question and answer questions in your question and answer, not in the chat, and we'll tackle them at the end. So Dr. Fakhri, the floor is yours. The virtual floor is yours. I appreciate you being here.
Thank you, Dr. Midlars. I really appreciate the introduction. I'm honored to be part of this great panel. It's a really exciting time in head and neck. I think, as outlined by the previous talks, all inspiring and really evolving really quickly. So I'm going to talk a little bit about the potential role of HPV DNA in surveillance for oropharynx cancers. And so, as we think about what the potential role for HPV ctDNA is in surveillance, we have to think about how it would perform really at the very beginning, when the disease is present and highest, and how it changes and through the different phases of therapy. So I think it's also worthwhile to think about, what does HPV ctDNA mean, and where do we see HPV? It's beyond head and neck. So while we think about HPV ctDNA, and we as otolaryngologists are thinking about head and neck, it's also present in anal cancer and cervical cancer. the type distributions are different for anal and cervical cancer than they are for head and neck, but HPV is etiologically responsible for those malignancies as well. And when we think about it in head and neck, we've seen an increase in incidence of HPV-related oropharynx cancer in recent decades. We've seen that there's also an increase in prevalence of HPV-positive tumors in the same time period. And we've focused as a field on the role of HPV in oropharynx cancer, but I think it's also worthwhile to note that we are starting to see similar trends for sinonasal cancer. And Niall London, one of our colleagues, along with Dan Faden, have done really great work to demonstrate that HPV is etiologically responsible for this growing subset, and that this is a global phenomenon as well. So when we think about HPV in the head and neck, I think of really two hotspots and much smaller etiologic fractions or attributable fractions of HPV in the oral cavity and the hypopharynx, where you can see some P16 positivity, which I often think of as true, but unrelated, meaning it's not HPV related most of the time. And that sinonasal and oropharynx are really the two hotspots. So for the purposes of this talk, I'm really going to talk about oropharynx, but I just want to kind of lay that foundation, because when we think about HPV ctDNA, it is not always reflective of the oropharynx. It can be other sites. When we think about ctDNA, there are two ways really predominantly of sampling. Plasma really being the most common, and then saliva or oral rinses being the other. And then there are many ways of doing the detection of HPV ctDNA, and that will really inform the sensitivity. So when we think about at the time of diagnosis, ctDNA and how good it is at diagnosing really, or telling us whether or not HPV is there for oropharynx cancers, what we see is that 10 to 15% of patients with HPV positive oropharynx cancer at the time of diagnosis, when their tumor is in the largest volume that it's going to be essentially, don't have ctDNA that is detectable. That can be either just because the tumor volume is a little bit lower, either by T-stage or nodal disease, or they can have an integrated HPV. But that would result in significant misclassification. There are variable properties of ctDNA detection depending on the collection medium, so whether it's plasma or oral rinse, and whether or not we use ddPCR or NGS testing to identify the ctDNA. There are also differences in terms of the anatomic site. So this is work by Dan Faden, and what they demonstrated in a systematic review is that sensitivity differs for oropharynx versus anogenital malignancies. And while sensitivity is pretty low when we look at it, when we pool different data, I do want to show that there is optimism. There are methods that are coming down the pike of really ultra-sensitive ways of detecting ctDNA, and the DeepSeq assay, which is NGS-based, has good performance characteristics with high sensitivity, specificity, and negative and positive predictive values. Glenn Hanna at Dana-Farber has shown that ctDNA levels change with burden of disease. And so what they show as a group is that you can kind of stratify local regional disease versus distant metastatic disease and the different sites based on levels of ctDNA. While they've shown this, and radiographically other groups have also shown this, there are no established clinical cutoffs. And so this is really just, in research showing that there are ctDNA varies with site of disease. So when we think about it in terms of using it for surveillance, we want to know, well, how does it vary with disease response? The Michigan group has shown that, yes, ctDNA does show a response in terms of treatment, and that you can use that to prognosticate. And so when we see an early decrease in disease and ctDNA, patients are less likely to progress. We have, along with Maura Gilson, we did a study at Hopkins and Ohio State, and this was using oral HPV rather than plasma HPV DNA. And what we showed is that from week to week during radiation therapy, we could see that the prevalence of HPV DNA declined, and therefore we could see a response in terms of treatment. This was really isolated to the tumor type of infection. And so if we looked at non-tumor type infections, we see that there was no change through the course of treatment. So week to week, if there was an HPV tumor type that was there but not related to the tumor, then there was really no change in viral load throughout treatment. And this is, again, work from Glenn Hanna's group. What they showed here is that we see different slopes in terms of the response to treatment, depending on the type of treatment that they have. So immunotherapy has a different slope than chemotherapy response. And this kind of gets at the slide that Neil had shown earlier in terms of differences between chemotherapy and immunotherapy. But you have different response times, essentially, to each of the therapies that are seen in ctDNA, and they trail in some. So in terms of post-treatment, what can we tell from ctDNA? What we know is that if we can detect ctDNA after treatment, that is a harbinger of recurrence. And so we've shown, and this has really been work that was done early, over 10 years ago now. Joe Calfano had done some of the initial work, and Bert Vogelsteins and Nishan Agrawal later did it. And they showed that if you can detect ctDNA after treatment, it's associated with worse prognosis. And so you see what I think some groups have termed as the alligator or crocodile survival curves, where having no ctDNA after treatment is associated with significantly improved prognosis. And I put this in here. This is data from the Mayo group, where they de-escalated patients in terms of their therapy. And even in de-escalated groups, if you can detect ctDNA after treatment, they have significantly worse prognosis. So it's good for prognostication. And this is data from looking at ctDNA after surgery, where you can see it's really dynamic, and you see these drops within hours of surgery. And if you look at in lymphatics, also, you can use the presence of ctDNA in lymphatic fluid to prognosticate as well after surgery. And so this is all, I think points towards, I think there's a lot of optimism in the field in terms of using ctDNA, in terms of prognosticating, and in terms of surveillance. And so this is an elegant study that was done at Memorial Sloan Kettering, led by Nancy Lee, and they focused on HPV-positive oropharynx cancer patients who had ctDNA present. It was detectable before treatment. They underwent surgery, and then they used the ctDNA after surgery to prognosticate and say, can we have a group that has continued surveillance using ctDNA? And then once if they become detectable, they would get delayed radiation therapy. And so this study ended up enrolling 12 patients before it was closed. And I think it was a really sobering trial for us as a field, as it, kind of showed the limitations of ctDNA. As you hear on the panel on the right, you can see there were 3 patients who recurred. And unfortunately, all 3 of these patients recurred without preceding ctDNA positivity. So they were ctDNA negative, and then just with routine imaging had detected recurrences. And then they had one that was ctDNA positive and ended up getting delayed adjuvant radiation therapy. And there were 2 people who had confirmatory ctDNA tests, meaning they came in, presented clinically, and at the same time, their ctDNA test was positive. So the ctDNA didn't point them towards recurrence. So the study closed because it had a high gross recurrence rate and closed early. And so when they looked at their sensitivity and specificity, what they found is that the sensitivity was about 67% for gross disease, and that the false negative rate was actually pretty high. So how do we kind of synthesize this and think about it in terms of surveillance clinically? And I put this in here, just think about why do we think about surveillance? And this is, just to show that our imaging is really not great for surveillance. It's as good as a flip of a coin, essentially. And if you look at this data, and this is not just head and neck, it's across cancer sites, what you see is that in some cases, imaging performs worse than just clinical surveillance. So this is data from Eleni Redig's group up in Dana-Farber. And what they did is they looked at, what would it look like to use biomarker-guided surveillance. So they did usual surveillance. They added plasma ctDNA at their follow-up visits. For surgery, they did it 2 to 3 weeks post-operatively. After radiation, they did it 6 weeks after completion. And then after either surgery or radiation, patients got every 3 months ctDNA detection for up to 2 years. If a patient had a positive or indeterminate test, it was repeated to ensure that it was either, if it was indeterminate, it was going to flip to negative, or if it was positive, to see if they were positive. And if a patient had 2 serial detectable or indeterminate results, then they got a PET CT. And so I think one of the values of this study is to really think about what would be our clinical algorithm if we had a positive test. What is it? Do we get a confirmatory test? And what does the imaging look like? Patients who had a single indeterminate test with a negative follow-up did not end up getting imaging. So they had to have 2 indeterminate tests to get a PET scan. And then anyone who had detectable ctDNA or indeterminate ctDNA went into an intensive imaging path where they got repeat imaging every 8 weeks up to 6 months. And so what they found is they classified the groups into true negatives, true positives, false negatives, and false positives. And what they reported is a 91% sensitivity overall. When they limited to those who had a baseline positive test, it was, overall it was 73%. And if they limited to those who had a baseline positive test, it was 91%. So the performance improved then. And the positive predictive value of a ctDNA test was 79%. And so when they kind of spelled out all of their patients in the different groups, what they reported is that 33% of those who had HPV ctDNA were confirmatory true positives, meaning that those patients had clinical disease that was detectable, and at the same time, they had ctDNA. So the ctDNA didn't point them to anywhere. And this is kind of consistent with the Memorial Sloan Kettering data. So if we remove those who are confirmatory true positives, meaning in a surveillance setting, it doesn't really help us to have their ctDNA, and we do our 4x4 table again, 2x2 table again, and think about sensitivity, specificity, and predictive value, and recalculate the performance characteristics, we see that the sensitivity drops to 40%, and the positive predictive value is 60%. And so this is really, a true world surveillance scenario of how ctDNA plasma performed. And this is consistent with, a lot of previous data using, in some cases, PCR or less advanced, I should say, ctDNA. Am I getting I should end soon? Sorry. So what else do we have to think about when we think about surveillance? We need to think about lead time. So are we finding out that someone is at risk well before they have clinically evident disease? And based on the studies, it's really median, it's somewhere between 4 to 6 months is what we see in the literature. So, what do we, when I think about it, in terms of ctDNA, what is it that we have to show? Because I think what you can see is that in the previous study, there was an intensive imaging for people up to 6 months. We have low sensitivity, essentially, lower than we would like for a clinical assay and what is used in kind of other anatomic sites. And so is it worthwhile? Because we add cost for these patients. We add a lot of more testing. So in addition to the cost, it's the time of the patient's time away from work. And there's anxiety that is associated with all this. So what is it that we need to know? Really what we need to know is in a randomized study that the ctDNA surveillance group where patients are HPV ctDNA negative, they're going to do better than the ctDNA positive group. And that is better than clinical surveillance. And so, that is really what we would need to demonstrate efficacy. Or, and along with that, we would need cost data, quality of life data, and to demonstrate that we're reducing resource needs. And maybe when we do that study, we'll also just show that, both groups are similar, but still better than clinical surveillance. But that's really the kind of data I think that we need, and where we would really rigorously know that you do the ctDNA testing before imaging each time, rather than, kind of leaving it up to chance. So what are other questions that we need to answer in terms of using this clinically? So we need to have a better idea in terms of lead time, because right now we don't know whether we're really actually catching anything earlier rather than later. What is the risk-benefit ratio? Are we seeing a survival benefit, or is this something that we're doing because we think that we are improving survival? I think now, there is a lead time bias because what you hear people say is, well, I'm catching it earlier than I otherwise would have, but are we really changing survival? We don't know at this point. How often should we be testing people? What is the clinical algorithm after we test people? What are the performance characteristics? A lot of the data that we have are in really small studies, not in large sample sizes. Does the knowledge alter our clinical course? How should we as physicians be counseling our patients? And what is the cost effectiveness? Also, what is the role of other cancers? Patients can have second primaries. We've all seen patients with Oropharynx cancers who also have an anogenital cancer. So once the ctDNA is positive, is it the Oropharynx or is it something else that we're looking at? And so how do we evaluate the other sites at the same time? So I say all of this, and I also recognize that this is an area in the field that is highly controversial and everyone has different practices. And this is like much of the world that we're in, unfortunately, where we both look at the same set of data, but we come to vastly different conclusions. And so I put this slide in here just to acknowledge that there are very different perspectives when we look at the same data, and people have very different interpretations. And so what I think is needed is a prospective study to delineate the schedule, order of samples, collections, and to really demonstrate, are we improving survival, and are we reducing resources, or are we increasing cost at the same time? And I think I'm over time, so I am going to just end on one thought, which is when we look at in the cardiology world, when they introduced an assay of high sensitivity troponins. You know, when I was in training, when Wojtek was the junior resident with me, we were using conventional troponins. But as cardiologists introduced, and you know, beyond cardiologists, the high sensitivity troponins, they were really able to describe with using high numbers of participants what high sensitivity troponin means, what it means early in the period, what it means later in the period, what it means if the different levels for females versus males, what it means within an hour, within 3 hours, and then later, and then really delineated an algorithm for what that means and how you should treat different patients. And so we're not really there. And you know, there is a framework for us to think about how we adopt this into clinical care. And lastly, the consortiums that have kind of weighed in on it have really said that this is not really ready for prime time quite yet. And there are 2 societies essentially that have done that. So I'll end there. Thank you very much.
Thank you, Dr. Fakhri. I think, you know, this is where it's being used I mean, not maybe everywhere, but we're seeing it used all you know, community, at least in the US, and otherwise. Again, this is still a test that is not cheap in many parts of the world, but we have to be very careful what that data means and how we act on it. And I think that's where we still need a lot more work. So thank you for leading those efforts for us all, and keeping us honest with what we know, what we don't know, and continue to push for better clarity. So I appreciate it. I'll turn it over to Dr. Tsai, you know, please, for final thoughts. And I think we've handled all Q&As. So if there are any other questions, please put them into the Q&A chat session, or the Q&A section. We'll still tackle them. Thank you for the speakers for handling them as we move along.
Before we conclude, I will take a brief moment on behalf of the Taiwan Head and Neck Society to thank AAOHNSF for this wonderful collaboration. It has been an absolute privilege to bridge our societies across the globe today and share in this vital exchange of knowledge. With over 1,100 participants joining us from 123 countries, this is truly an excellent effort across time zones. Thank you to our brilliant speakers for taking us through the novel technologies and treatment strategies for head and neck cancers, and from robotics to immunotherapy to adapted oncologic surgery, and then further on to circulating tumor DNA on HPV. Well, thank you for everybody, all the attendees, for your active participation. I will now turn the time over to Dr. Sorna.
Thank you. Thank you so much. Thank you to all the panelists and moderators. Thank you to the attendees. It was a wonderful session as always. I hope everybody learned from each other. I want to bring to your attention so that we're going to have the next global grand rounds that are planned for May 9th of 2026 at the same time. And this global grand round is going to be in collaboration with Pan American Society of Oncologic and Head and Neck Surgery on global perspectives on modern rhinoplasty. Please also join and listen in to the podcasts that are run by our CEO, Dr. Rahul Shah, on Voices of Laryngologists. They are published every Tuesday, and thought leaders get interviewed and share some of the insights and latest issues on impacting your practices and patient care and in general field of otolaryngology. Our annual meeting is going to be in Los Angeles, California, October 17th to 20th. So watch out for the registration. It's going to open in June. So please consider attending, register, attend. It's usually a wonderful event where people from all over the world get together. It's an opportunity for networking, education, and an introduction to various innovative research and developments. We do have international grants and scholarships. Dr. Meyer's Global Fund, the Educational Fund, which is intended for low-income country otolaryngologists, and that allows for physicians to take advantage of educational resources, and then it supports travel registration to attend the annual meeting and access some of the online educational tools. We also have International Visiting Scholarship Program. We have several options, so please take a look at that, because again, some of those scholarships allow selected participants from international members to help with offset the travel grants and membership for American surgery, meeting registration, and also opportunity to participate in academic observerships at the United States in the various institutions. And at one point that applications are due by April 15th, so make sure to submit the applications if interested. Also, international members have a lot of opportunities. You can please join as a members. There's also various discounted rates for membership, and there are wonderful educational opportunities that are provided for our members. So please take advantage of that and log into the scan a QR code or log into the website. And with that, I once again want to thank everyone, all the participants, wonderful thoughts, wonderful collaboration. Thank you to the Taiwanese Head and Neck Society. For all the attendees, the certificates and session recordings are going to be available next week. So that's going to get alerted through the email. And with that, again, thank you very much and have a wonderful weekend.